It's my very special pleasure to introduce our first speaker this morning, Dr. Brenda Allen. Dr. Allen is someone that I've had the opportunity to interact with in a number of educational forums and also collaborate with in looking at some issues around faculty recruitment and some other important issues in the Department of Surgery. She spent time with us before at the directors and executive committee levels. Dr. Allen is Vice Chancellor for Diversity and Inclusion at the University of Colorado, Denver, and the Anschutz Medical Campus and Professor of Communication. And just by way of brief introduction, Dr. Allen was recruited to the University of Colorado in 1989 as an assistant professor. During the ensuing year, she's climbed the academic rank and now holds the rank of professor. Has also served as department chair and associate dean. Dr. Allen assumed the role of Chief Diversity Officer for the institution in 2012. Brenda, I don't want to spend too much time going through all the details of your career in as much as it would take the majority of the time that we have allotted to us this morning, but I will say Dr. Allen has written a very important book, has also been extremely helpful and very proactive in helping us develop as an institution appropriate policies, appropriate guidelines, and really making important efforts in the areas of diversity and inclusion. This morning, the presentation topic that Dr. Allen is going to spend time sharing with us is implicit bias. And I do think that this is an especially good group to hear some information on implicit bias. I think that all of us, based on our scientific background, based on our clinical backgrounds, feel that we try to use all the available information to make as well-informed a decision as we can as we interact with peers, with learners, and with students. But I will say that the hundreds of decisions and assessments that I think I make on a weekly basis, a great number of them are influenced by things that I don't see are influencing me. And I think to the extent that we can identify the sources of those unseen biases, we'll be able to make much better decisions that are more helpful and fairer to those that are around us and more fair to ourselves. So, Dr. Allen, thank you so much for spending time with us. Really look forward to your lecture.
Thank you very much. Good morning. I am very pleased to talk with you this morning about implicit bias. And in preparing for this talk, I realized that a way to address it would be to focus in particular on gender equity. I have no conflicts to report. So our objectives today are shown, and as I strive to achieve them, again, I'm going to focus in particular on surgery as well as on gender dynamics within surgery to define implicit bias, delineate ways that implicit bias occurs, and identify some strategies and techniques for mitigating implicit bias. Last week, I attended a summit for the Center for Legal Inclusiveness, and I attended a session on implicit bias. During that session, I was very surprised to hear the presenter refer to what I consider a classic brain teaser, which is about a man and his son get in a horrible auto accident. Raise your hand if you know this one. And yes, so you're familiar with it. So when the son is on the operating table, the surgeon looks down and says, "I can't operate, that's my son. What's going on here?" So I was surprised not only that the presenter referred to this, what I consider classic brain teaser, but also that many in the audience had not heard of it. Furthermore, many of them could not figure it out. How could that be? The father was in the accident. How could the surgeon say, "That is my son"? So this to me is a stark illustration of how all of us, in reference to the introduction, all of us have been socialized regarding who belongs in what kinds of positions in society. And as we're figuring things out, as we're engaging with one another, as we're making formal and informal decisions, we may be likely to unconsciously draw upon those biases, those expectations, and those stereotypes. And just in case there may be one or two who don't know the punchline, the surgeon was the kid's mother. So, and therefore, it shows that the tendency to view surgeons as males could not, figure out. Now, on the other hand, in terms of really thinking about diversity and inclusion, it also could have been that the son had two dads, okay? So, if you think about this issue, also what came to mind to me as I conducted some research, in particular on gender equity and surgery, I found this example, and I also found a wealth of information and insights that I strongly encourage you all to consult if you, and I also encourage you to take this particular opportunity very seriously, and in addition to the work you're already doing, to expand and extend that. So this is the I Look Like a Surgeon campaign. How many of you are familiar with that campaign? This actually began in 2015, and there are many photos of women in their looking down as if they're at the operating table. So again, I was tickled to see how this aligns with that idea of that age-old brain teaser. And this particular campaign is exciting because of the positive approach that it is taking. It seeks to bring a community of surgeons together to communicate and collaborate to address stereotypes in surgery that actually affect women and men, and therefore affect all surgeons and all things related to surgical care. It aims to celebrate diversity in surgery and show that a surgeon can indeed be anyone by challenging stereotypes. And one dynamic related to the impetus for this campaign is implicit bias. But what is implicit bias? I'm sure many of you are familiar with this concept and also have participated in professional development or education. I, however, think that it's hard to get too much of it. Every time I do these presentations, I usually have an example of my latest revelation of how deeply ingrained these ideas of stereotypes against others or for others are. So implicit bias refers to attitudes or stereotypes about individuals or groups that affect our understanding, actions, and decisions in an unconscious manner. These biases encompass both favorable and unfavorable assessments and are activated involuntarily and without our awareness or intentional control. They reside deep in our subconscious, and they're different from known biases that we have. For instance, my favorite color is purple. So it's not available through introspection, these implicit biases, but we harbor them, and they can cause us to have feelings and attitudes about others based on characteristics such as gender, race, ethnicity, age, ability status, sexual orientation, just to name a few. These associations develop over a course of a lifetime, beginning at a very early age through exposure to direct and indirect messages from a wide variety of sources: our family, our religious community, our spiritual community, education, the media, our peers, and so forth. And repeated reinforcement helps us to strengthen those associations of characteristics or traits or possibilities with particular human embodiments. And they, again, can be either positive or negative. For example, a stereotype that Asians are better at math, or a stereotype that women are worse at math. Here are some of the categories of human identity related to bias. And notice in the center, the key ones are physical abilities or qualities, age, sexual orientation, identity, gender, race, and ethnicity, and also the ways that those can overlap. And if I polled the audience and asked you, could you name stereotypes, negative or positive, about each of those groups, how many of you think you could name stereotypes? Not that you believe them, but that you could list stereotypes about these groups. And indeed, if we could poll it, we'd also find strong similarity in terms of the specific stereotypes we listed. So the fact that we are aware of those stereotypes actually then illustrates that they're in here. They are in there, whether they correspond with our actual values or not. And it's harder for those of us, like myself, who don't view ourselves as prejudiced or ist in any way, racist, sexist, etc., ableist, and yet a wide variety of research across multiple disciplines and fields repeatedly and convincingly shows us that we're all subject to implicit bias. So with that definition of implicit bias, it is important to pause and really consider, why does it matter? Why does implicit bias matter in general in society, and why does it matter specifically for surgery? Again, if I had the time, I'd try to ascertain from you as wide a range, as in-depth and superficial in terms of reasons why this matters. But I'm just going to list a few. For one, in general, and in surgery, it can influence our attitudes and our behavior. And it also can occur in formal and informal decision making. If you just think about your average, if you have such a thing as an average day, your average day, all the kinds of decisions that you make, formal and informal, some of which you are aware at that point cognitively, I am now making a decision, versus routinely and almost knee-jerk response, you're just moving along, sometimes on cruise control. Well, that's when those notions, ways, associations we've been socialized about one another, including, by the way, about members of our own groups. So I, as a Black woman, am as likely to have those negative associations about being an African American woman or woman of color or woman as others might have, even as I might also hold some positions of privilege and assumptions in the positive about persons who are straight, like I am. So this is important to understand, that then when we think about the range of decision makings and interactions that you do on a day-to-day basis, then it can influence such things as whom to mentor, who to invite to external events, who to ask to work on a research project, who to recognize for their contributions, or who to even deem credible in a particular context. Research on implicit bias related to medicine has covered these topics, as well as differential treatment, diagnosis, prescribed care, patient well-being and compliance, physician-patient interactions, clinical decision-making, and medical school education. This research also looks, in addition to thinking about clinical care, practice, et cetera, thinks about how do prospective and current members of the medical profession engage and interact with one another. And that's what I'm primarily going to focus on today in terms of looking at gender equity. Implicit bias then matters in those ways. It also matters because it's important to believe that implicit bias matters if, indeed, the idea is incompatible with our conscious values. Because if there's a sense of, well, no, I don't do that, then you may be less likely to actively and proactively try to disrupt the tendencies toward implicit bias. So that's why it also matters. It also, mitigating implicit bias can really help to optimize the value of a more diverse profession. And I trust that you have a sense of why this matters. That in addition to being a moral, ethical imperative, in addition to fulfilling what we believe in terms of equality and justice for all, there's also the idea that increasing diversity, and specifically, again, focusing on women, but not leaving out underrepresented in medicine in terms of race, ethnicity, et cetera, can help to address health disparities and improve patient outcomes. Also, this can be helpful in terms of representation in leadership roles and across the potential career path of someone in surgery. So with that notion of implicit bias mattering, and again, if we had time, I'd love to delve even more deeply. I encourage you to keep thinking about this topic and talking among yourselves about, well, why really does this matter? Why should we put attention to this topic? In terms of thinking about gender equity, and particularly in surgery, again, there's a wide wealth of research, and I've cited some here. I encourage you, once again, to take a look at that, to share that with one another, to provide opportunities to not only read and understand what's being said in this research, but also get ideas about, so what, now what? Well, the number of women graduating from medical school, as you may know, has increased substantially over the past decades. At the same time, although women comprised almost half of medical school graduates in the United States in 2013 and 2014, they remain underrepresented in traditionally male-dominated specialties. I'm very honored that I've been doing some work in radiology, both here and I've done a couple of presentations nationally, and there's some similar dynamics in radiology that include these that I've listed here, as well as ideas shown in the next chart about where you find women and men across the career path, as well as where you find women and men in terms of subspecialties. The more prestigious, quote unquote, or the higher paid, the fewer you see women in those roles. And it is also important to note that similar dynamics exist when we look at underrepresented in medicine in terms of race and ethnicity. Most of the research currently, however, tends to focus on gender and looking at women and men and contrasting them. So as you see here, women represent about 10% of chairs in surgery. The largest gender gaps in salary are often in surgical professions. And the percentage of female full professors is increasing disproportionately slower than in female medical students and surgery residents. And this particular chart is one that Dr. Caprice Greenberg included in her address last year, and which she talked about the proportion of women represented, as I've mentioned previously, across the spectrum. And so this really shows you what happens. And looking at that, thinking about if these trends persist at this pace, many decades will pass before the increases of women into a profession are fully reflected at every step of the academic ladder. And the prediction says that surgery residents could have equal proportions of women and men by the year 2028, but an equal number across all the way up, in particular for full professors and other leadership roles, is unlikely to be achieved until 2096 without a change in the trends, without active, intentional, proactive approaches to striving to mitigate implicit bias, as well as, obviously, explicit bias. But again, for our purposes today, we're focusing on implicit bias. So here's a little bit in terms of the kinds of experiences that data, research reports, as well as anecdotal data reveal. So one is perceived gender-based discrimination. And again, that implicit bias, both for or against persons in terms of their social identities, during medical school, residency, practice, and beyond. And these perceptions, and actually oftentimes documented and substantiated, of course, include observed as well as experienced gender bias, as well as negative, stereotypical, and gendered expectations of male and female surgeons. And these overt and covert kinds of processes include verbal exchanges, a sense of lack of respect, patronizing behaviors, differential treatment, bias against pregnancy, lack of or limited mentorship, disparities in resources, double standards. Oftentimes there's invoked this notion still of an old boys network and barriers to advancement. These can have a cumulative impact on one's career. Research shows that although some women in academic surgery may report feeling very well prepared and capable of excelling early on, they later perceive the most salient barrier as, quote, interactional bias, unquote. In Dr. Patrice Greenberg's Association for Academic Surgery presidential address in 2017 entitled Sticky Floors and Glass Ceilings, she shares research and anecdotal perspectives as well as recommendations, which leads me to close out with some of my recommendations, some of which overlap with hers. But again, I encourage you to take a look at some of the resources and others that I have mentioned. So I think it's important to think about what to do, the so what, now what, both on an individual level as well as you think about departmentally, organizationally, or any kind of collective or cohort to which you belong. On an individual basis, it's important to remember, recognize, acknowledge we all have biases. It doesn't make us bad people. Our thoughts are not us. Also, commit to managing your biases. Oftentimes, I do these kinds of presentations and people say, I just wish so-and-so were here. And my response to them is, you are here. And there's something you can do with you as well as whatever your sphere of influence might be. Also, learn more about biases and how they operate. Pretty fascinating work in terms of neuroscience, in terms as well of ways that when we recognize and acknowledge, then we have the potential to do something differently or better. You learn more about the kinds of things that women have reported experiencing time and time again. And by the way, it's not at all limited to surgery. As Vice Chancellor for Diversity and Inclusion and also as an expert in diversity and inclusion in higher education, I both witness and hear about and read about these kinds of dynamics, not just for gender, but other aspects of identity that are so very predictable. And once people understand the kinds of things that happen that they may be likely to do, then they can get in front of it. In addition, be mindful of what I call TUI, thinking under the influence of these stereotypes. Kind of check yourself, watch out for it. And solicit feedback. Ask those around you to tell you if they believe you've done something that somehow indicates implicit bias. On an organizational, institutional level, it's really important to take a comprehensive, strategic approach. And my review of the Department of Surgery's website implies that you're doing some of these already, and I commend you for that. Within that strategic approach, identify, well, first of all, make diversity, inclusion, mitigating bias central and key and something everyone's responsible for, accountable for, but also celebrated for. And you already have diversity identified as one of the values for the department. Identify and implement best practices. I found, and perhaps you all are aware of, at the University of Michigan, their Department of Surgery is really doing what appears to be impressive work that corresponds with the university's Michigan promise. And so they have a promise in surgery related to these issues. Also, look at or refer to the Association of Women Surgeons statement on gender salary equity. In addition to that strategic approach, gather data. The data will show patterns you may not even be consciously aware of in terms of who's being assigned what, who's being promoted, who's getting resources, formal and informal, who's been invited and included in those kinds of things for which you don't necessarily have specific criteria and yet make a difference in terms of one's potential to succeed and to excel. Gather information, climate surveys, especially if you administer these kinds of climate surveys, you help people that you're soliciting know you're going to take it seriously. And by the way, be willing to be perhaps disappointed in terms of what you may find people report is going on right in your, not even your backyard, in your clinical setting. And, however, approach it with the intention to do better, because those who know better can indeed do better. Identify and implement best practices, I've said, provide training and professional development across a number of things. So this idea, for instance, of women advancing, mentorship matters, helping people know how to mentor well, and few of us really do that. We may do it well, but if we do, it's not usually because someone has helped us and taught us how to do it. Leadership development in terms of inclusive leadership, implicit bias. There are many, many topics that could be helpful in terms of what we're talking about. Equitable decision-making process, and so forth. So, foster awareness and accountability. And finally, cultivate an inclusive culture. In her presentation, Dr. Greenberg said that programs to raise awareness of gender-based discrimination and promote gender equality in the surgical workplace should occur throughout training and as part of continuing medical education, and should reach operating room, inpatient, administrative, clerical, and nursing staff, as well as physicians, teachers, and students. To have a more inclusive culture, it's important to foster respect, to strive for dialogue, to be an active bystander if you observe something, in particular if you're in a role of power or authority, to say something, to provide resources. In conclusion, our focus on implicit bias, I must note, should not overshadow the reality of explicit bias that still exists and continues to be a pressing issue in our world. However, learning about and striving to mitigate implicit bias can play a vital role in enhancing diversity and fostering inclusion in surgery to help you achieve your vision to improve every life. Thank you.
Dr. Allen, that was a wonderful presentation. Don't leave quite yet. I'm going to ask if anyone have any. We have a roving microphone. Questions or comments for Dr. Allen on this extraordinarily important topic? While you're thinking, I will point out that, as you mentioned, we work hard on this in the Department of Surgery. Again, I think the theme is an important one, that we don't sometimes know what we don't know. You can look at a situation and think that you're making the right decisions, you're influenced the right way. But if it doesn't occur to you, then that's a real issue. I think your recommendations regarding looking at empiric data, looking for evidence that we're either succeeding or not succeeding. In terms of additional educational opportunities, it's wonderful for you to spend time with us this morning. Where else can we turn? What other sources are there that you can recommend that we look at individually? Because sometimes you don't want to admit that you need work on this, so something you can access yourself may be helpful, or things that we can do as a group.
I think my voice can carry. Thank you for those questions. First of all, please see me as a strong partner in this work, to come and work on an individual basis, departmental basis. I really appreciate the expertise and experience that I have, and it's part of my job to share that. Also, on an individual level, there's an intriguing test called the Implicit Association Test. Any of you heard of that? It's an online test at Harvard, decades old, that actually invites you through quick, rapid kind of reactions, responses to pictures and phrases and associations to get a sense of how have you been socialized regarding some of these social identity categories. Every time I take them, I'm reminded that, after all, I'm human too. And one example for me is whenever I do the one on gender, I still have, despite my own background, despite my experiences, despite me doing this work, I have a strong association of women with home and family and men with career and work. So the Implicit Association Test, or IAT, is a helpful thing you can do for yourself. Also, I would encourage you to, if you haven't read the transcript or listened to Dr. Greenberg's presentation, wealth of information on that one. So those are some that I can think of offhand, and share with one another if you have resources.
Very good. Thank you so much. And I know that you have limited time and bandwidth. If we are going to do some individual efforts, smaller groups, divisions, training programs, could you possibly come and spend time occasionally with us on a more interactive one-to-one basis?
Yes, I would welcome that opportunity. I would welcome that opportunity to work in any capacity that you would like, in particular, developing a strategic approach to this work. And I'm so pleased when I do this work with particular groups to see usually there's some kind of model or exemplar. And what I saw so far at the University of Michigan, we could use that or other resources to develop this strategic approach with measurable data, with outcomes and so forth. And I welcome that opportunity. Individually, if any of you want to share anything with me, either confidentially or to support and help us to advance this work, please email me. I would love to hear from you.
Thank you, Dr. Allen, so very much for being here with us today.